name is Michael Ritchie, and we're going to be talking about the guidelines and the physiology of heart failure. So heart failure has two definitions. So one of them is just a chronic and progressive condition in which the heart muscle is unable to pump enough blood to meet the body's needs. Or it can be a complex clinical syndrome with symptoms and signs that result from structural or functional impairment of ventricular filling or ejection of blood. The reason that we talk about it is that about 310,000 heart failure deaths in 2014 and 1.2 million hospitalizations in 2017. So it's a significant burden for patients across the country. There's been a decrease in the incidence of heart failure with reduced EF, but an increase in the incidence of heart failure with preserved EF. So when we talk about the causes of heart failure, there's a lot of causes of heart failure. There's coronary artery disease, which is the most common cause of heart failure. There's non-ischemic causes, which is going to be like rheumatological or autoimmune. There's genetic or familial conditions that lead to heart failure. Heart rhythm related, so like tachycardia induced. Hypertension, chronic hypertension can lead to heart failure. Infiltrative, that could be sarcoid or amyloid or hemochromatosis. There's also myocarditis or inflammation that can cause it. It can be peripartum. Stress cardiomyopathy, also known as Takotsubo's. Substance abuse can also lead to cardiomyopathy. Next, we're going to talk about like in terms of the stages of heart failure, like how we determine how well or poorly someone doing is. We typically talk about it in terms of saying that they're symptomatic heart failure or advanced heart failure. One of the ways that we look at it is through the ACC or AHA stages of heart failure. So that goes stage A, stage B, stage C, and stage D. Stage A is just going to be people at risk for heart failure. So people with diabetes, people with obesity, people that just have familial variants that lead to cardiomyopathy. So people that are at risk. Once you get to stage B, you're going to start talking about like pre-heart failure. So they're going to have like some sort of structural heart disease, or they're going to have evidence of elevated filling pressure. So high volumes in their heart. That's going to be talking about heart failure. And then they'll have certain risk factors that will say that they're at risk for having the going towards heart failure kind of as more advanced. They already have the structural changes. And then as you get to stage C, that's where you actually have symptomatic heart failure. That's where you're going to have your shortness of breath, your dyspnea, your orthopnea. And then advanced is going to be your marked symptoms. So recurrent hospitalizations, you're unable to kind of get them treated through there. The most common one that we know about is going to be the New York Heart Association classifications, and that's going to be class 1 through class 4. Class 1 is going to be basically no limitations to activity. Class 2 are going to be symptoms with moderate exertion. Class 3 is going to be symptoms with mild exertion. And then class 4 is going to be symptoms at rest. So it's more of like how much can you do before you start having symptoms? And then a lot of our medications and what we do depend on whether or not we think somebody is class 2, class 3, or class 4. There are many types of heart failure, and so understanding how to name them all. So there's heart failure with reduced EF. So when most people talk about heart failure, that's kind of what they're talking about. They're assuming that it's someone with reduced ejection fraction. There's also heart failure with preserved ejection fraction. So it's going to be a normal EF. There's in between that 40% and 50%. So this is going to be heart failure with mildly reduced ejection fraction. And then there's right-sided heart failure. And then there's valvular heart failure, where you may have like a flail leaflet or something wrong with one of your valves that inhibit you from having appropriate cardiac output. But what you need is, in order to have the diagnosis, is that you need to have evidence of increased filling pressures. So you need to have like high CBP, high wedge pressure, high BNP, something that says that you're having high filling pressures. So now we're going to briefly talk about the hemodynamics, so we can kind of talk about why the medications we give, and we can talk about like the physiology of why this is such a difficult disease. So breaking down cardiac output. Cardiac output is heart rate times stroke volume. Stroke volume is broken down into 3 components: preload, contractility, and afterload. Now, preload is, I like to think about it as like a spring. So it's whenever the volume goes into the ventricle during diastole, it allows that ventricle to stretch, and that stretch is what allows the contractility to happen. So the amount of volume in your ventricle is what's going to determine how much it stretches. And so if you stretch it a little bit further, that spring is going to bounce back even more, and you're going to get a springier return, and your contractility is going to go up. If you overstretch it, just like with a spring, then it's going to over-distend everything. You're not going to be able to get that squeeze back. So if you look at how this is, you look at the end diastolic volume and kind of that stretch and how well that stroke volume or that squeeze is that if you start adding volume, you're going to get more and more squeeze up into a point, and then you'll actually see that curve start to plateau and even descend because it's stretching out, and the spring is stretched out too far. Measuring preload, we typically talk about CVP, or central venous pressure, on the right side. We talk about wedge or PO, pulmonary artery occlusion pressure, PAOP, on the left side. The reason that it doesn't necessarily show a lot of correlation, or the reason that there's difficulty with it, is because CVP is a pressure, it's central venous pressure, and it's used to estimate the right atrial pressure, which is used to estimate the right ventricular end diastolic pressure, which is a surrogate marker for right ventricular end diastolic volume. So it's an estimation of a surrogate. So you could see how it just wouldn't be as accurate. And the same thing is true for the other side. Your wedge pressure is an estimation of your left atrial pressure, which is an estimation of your left ventricular end diastolic pressure, which is a surrogate for your left ventricular end diastolic volume. So you're using a pressure to estimate a volume. And there's a lot of fallacies whenever you do that. If you look here, the normal one being on the left, and then you have the middle with LVH, or left ventricular hypertrophy with diastolic dysfunction, and then the one all the way to the right would be your dilated cardiomyopathy. They actually have the exact same amount of pressure. Now, they have much different volumes within their ventricle, but they have the exact same amount of pressure, because one of them with the LVH has a pressure problem, and the one with the low EF, dilated cardiomyopathy, has a volume problem, but they both end up with the same pressure whenever they're in exacerbation. I like to use Vexus when dealing with preload because it looks at the volume within the IVC, and it looks at pulsatility within the liver and the kidney. And so that way you're using a volume to estimate a volume, which is a much better correlation as you're going through. All right, so on the preload, you can use CVP, you can use wedge pressure, you can use Vexus. Like I said, I typically use Vexus. When dealing with contractility, most people will look at EF. That's the most common one. It's easily reproducible. You look on your echo, and you're going to do, this is Simpson's biplane, where you're going to look at the area during systole. You look at the volume during systole and the volume during diastole, and you're going to be able to determine what their ejection fraction is. And then last is afterload. So we typically look at afterload in terms of resistance. So I like to think of afterload as like a dam, and it's letting a certain amount of volume forward. If you increase the afterload, it's going to make much less blood go forward. And if you decrease the afterload, it's going to make a whole lot more blood go forward. It's going to be easier to kind of eject that blood. So that resistance is a derivation of Ohm's law, which says voltage equals current time resistance. So in systemic vasoresistance, when dealing with afterload, it is change in pressure divided by flow. So the change in pressure is MAP minus CVP, and then the flow is cardiac output. So MAP minus CVP divided by cardiac output, and then you multiply it by 80 to get from Wood units to dynes. So normal is about 800 to 1200 dynes. So what that means is your cardiac output is inversely proportional to your systemic vasoresistance. So if your cardiac output goes up, your SVR goes down. If your cardiac output goes down, your SVR goes up, and then the reverse being the true as well. So this is kind of how I break down cardiac output. You have your preload with your CVP, wedge or Vexus. You have your contractility with your EF, and you have your afterload with your SVR. Now, how does this deal with the physiology? So what happens is that if you look here, if you have decreased contractility, you're going to end up with decreased stroke volume. Decreased stroke volume will lead to the activation of the renin-angiotensin-aldosterone system, which will then squeeze down with the angiotensin, and you'll end up with increased afterload. Increased afterload will increase your ventricular wall stress because it's going to be harder for your heart to eject because it's have to pump against a higher dam. It's going to make it much harder for it to eject. It'll have to work harder. Because it has to work harder and has to pump against that higher dam, it's going to decrease that contractility further. Also, with decreased stroke volume, you're going to get more and more blood within your ventricle, because if it doesn't eject, it's going to stay in there. And as it stays in there, it'll increase preload and it'll keep distending and stending that ventricle. And it'll lead to ventricular dilatation, which will further decrease contractility. And so the decreased contractility that worsens stroke volume, which then turns around and worsens contractility, which then worsens stroke volume. So anytime that you have this feedback loop, people start to spiral, because now it's just working on itself and it's getting worse and worse and worse. So you have to do something to break this spiral, or they will continue to decline. The increased ventricular wall stress and the ventricular dilatation is what leads to that remodeling. So as you saw in that previous picture with that cardiomyopathy, is you end up with a very dilated left ventricle with very thin walls. And so that's part of that remodeling that happens with heart failure. So as you can see here, you have this dilated LV compared to the normal one, and you can see how the walls are thinner and it's more dilated out. You have decreased contractility, decreased stroke volume. You have this increase in your renin-angiotensin-aldosterone system. The increase in aldosterone leads to fluid, holding on to extra fluid, and then the angiotensin receptors is what's going to lead to that squeeze and that increase in afterload. You also get a catecholamine release. The body recognizes this low flow to the kidney as like a sign of stress, and it starts releasing catecholamines, which further leads to stress on the heart, because it squeezes down increases afterload by squeezing on the vasculature, as well as it just increases contractility and increases heart rate of the heart, leading to more stress. And then you see the increased preload, so that LV is just going to stretch and stretch and stretch and stretch, because if it can't eject the blood, then it just stays in there. These are all complications related to increased preload. So you have complications where you're going to get liver congestion, you can get ascites, you can get JVD, you can get kidney congestion and acute kidney injuries, you get lower extremity edema, you get pulmonary edema in your lungs with difficulty breathing. All of these things can happen from just increased preload. And you can see that kind of pulmonary vascular congestion on the x-ray here. So whenever you have decreased stroke volume, the body can't increase the stroke volume. So the body's response to that decrease in stroke volume is to increase its heart rate, because it's trying to maintain that cardiac output. As you increase your heart rate, you're going to have less ejection time, because you spend less and less time in that ejection phase because your heart rate's so fast. That leads to increased oxygen demand. It leads to increased cardiac work. It leads to increased preload, and it just further decompensates things as they have an increased heart rate. Now we're going to move on to the guidelines. Kind of how does this all fit together? What can we do to kind of reverse that spiral that's going down, and why we came to the results that we came to? So the first one, or main one, we're going to be talking about is heart failure with reduced ejection fraction. I think that has the best data behind it, and it has the things that you can do. So the heart failure guidelines is more of a holistic approach. So one of the first things they talk about is that patients should receive care from a multidisciplinary team. They should have a heart failure specialist involved. These patients require a lot of resources. They have a high mortality that we talked about. They get frequent hospitalizations. And so you want this multidisciplinary team to try to make sure they can get better. They want to address any barriers to self-care. They're going to hopefully try to keep them out of the hospital. And it does reduce rehospitalizations if you're able to do this multidisciplinary team. Additionally, this multidisciplinary team has been shown to reduce mortality. Patients should receive special education and support to facilitate their self-care. This a lot of times just means daily weights, understanding what it means whenever they're having signs of decompensation or they're having signs of fluid retention, so they can hopefully get to it early so they get less and less hospitalizations. They should be vaccinated against respiratory illnesses, because they're going to be more prone to getting sicker if they do get a respiratory illness. And then they should be screened for depression, social isolations. These things, it become very difficult to even like walk to the car or walk out of your house. So oftentimes they find themselves kind of more and more isolated. So it's something that they should be screened. I think the big thing to take away from medical treatment, though, is the 4 pillars. That's kind of how we describe it now. So the 4 pillars are beta blockers, ARNI has become the big one. So you can do an ACE inhibitor or an angiotensin receptor blocker or an ARB, but the big one that we talk about now is an ARNI, which is a combination drug between an angiotensin receptor blocker or ARB and a neprilysin inhibitor. And so that's a combination drug that is shown to be superior to the ACE inhibitor and the ARB and is ideal to put onto these people if they can tolerate it. A mineralocorticoid receptor antagonist, so like spironolactone or eplerenone, those are the ones that are going to be your MRAs that are going to be beneficial. And then last is your SGL2 inhibitors, which was a diabetes drug that then we found out was very successful in treating heart failure. What is the data behind these four pillars? So beta blockers, it suppresses catecholamines, which decreases work and oxygen demand. It upregulates beta receptors to increase that inotropic reserve to allow that squeeze. And it helps suppress that renin-angiotensin-aldosterone system that's kind of making all that spiral kind of occur. It also prolongs the diastolic phase and it improves coronary blood flow. And so it's actually a class 1A recommendation to get a specific beta blocker to reduce mortality. And those are going to be either carvedilol, bisoprolol, or metoprolol succinate. Those are the big three that you would need to pick from when doing it. The ARNIs, so this is an ARB and a neprilysin inhibitor. That is an enzyme that degrades natriuretic peptide as well as other peptides. And it's sacubitril and valsartan. And that has shown a significant reduction in cardiovascular death or hospitalizations compared to ACE inhibitors. So that has actually been, if you can, an ARNI should be used to prevent symptomatic heart failure and reduce mortality. That is a class 1A recommendation. In patients that are intolerant to an ARNI for one reason or another, then the backup would be an ACE inhibitor should be used there. And then if they're intolerant to an ACE inhibitor, then you should try to do an ARB. If you have a history of angioedema, unfortunately, ACE inhibitors and ARNIs, the neprilysin inhibitor and the ACE inhibitor do cause angioedema. So if you have a history of angioedema, you should not use an ARNI or an ACE inhibitor just because of that risk. Another thing to consider, if a patient is on an ACE inhibitor, because of that risk of angioedema, that they should have a 36-hour washout period before switching from an ACE inhibitor to an ARNI. If you're on an ARB and you want to switch to an ARNI, you don't need to do that washout period. It's specifically the ACE switching to an ARNI because of that risk of angioedema. Now, mineralocorticoid receptor antagonists, or MRAs, they're a diuretic that antagonizes aldosterone. Again, that's going to help kind of reverse that renin-angiotensin-aldosterone system, try to prevent that cycle from occurring. So it's supposed to it decreases mortality, hospitalizations, and sudden cardiac death. So in patients with New York Heart classification 2 through 4 should get an MRA, and it should reduce mortality. And that is a class 1A recommendation. And then we have our SGL2 receptor inhibitors. And so that inhibits the sodium glucose transport proteins in the nephron. It's shown to have a 31% reduction in heart failure hospitalizations. And it not even just with heart failure with reduced EF, it also occurs for heart failure with preserved EF. And so this is actually independent of its benefits of actually lowering glucose to target goals. So it is a class 1A recommendation that patients with symptomatic heart failure should be on an SGL2 inhibitor to reduce hospitalizations and mortality. Now, we're going to go outside those 4 pillars. So these are going to be things that are just kind of recommended in addition to kind of as needed. So in patients with fluid retention, diuretics are recommended to relieve congestion. It's going to improve symptoms to prevent worsening of heart failure. It's not going to improve mortality, but it is going to improve symptoms and kind of make everything better from a symptomatic standpoint. So it is a class 1B recommendation. In patients with congestive symptoms, thiazide plus a loop, or what we call dual nephron blockade, can be helpful to those who are not responding to loop diuretics by themselves. And that's also a class 1B. Bidil, which is a combination of hydralazine and isosorbide dinitrate, for the African American population with NYHA class 3 at 4 receiving optimal medical therapy already, Bidil is recommended to improve symptoms and reduce morbidity and mortality. That is a class 1A recommendation. I will say that if you, for some reason, cannot take an ACE or ARB or an ARNI, anything from that class, then Bidil is a reasonable substitution to make sure you add on there, so that you can continue to have the same benefits that you would have from that drug class if you're unable to tolerate that drug class. Patients with symptomatic heart failure cannot tolerate these. Bidil might be considered to reduce morbidity and mortality, and that's class 2C. So here's some other adjuncts. So ivabradine, it inhibits the pacemaker current that controls depolarization. It's going to further decrease that heart rate. So you're taking beta blockers, all those benefits of beta blockers, and let's say you've maxed out your beta blockers and you still have a heart rate more than 70, then they do recommend this to help reduce hospitalizations and mortality. That's a class 2B recommendation. And then patients who are symptomatic, despite that, all those 4 pillars, digoxin might be considered. It is an inotrope. It also can reduce heart rate, and it has been shown to be beneficial in decreasing hospitalizations. And then varisequat is a guanylate cyclase stimulant, and that will actually help with patients with worsening heart failure and reduce hospitalizations and mortality. Again, class 2B. So these are adjuncts outside the pillars that once you've kind of optimized your goal-directed medical therapy, if you're still not getting what you need from those, these are things you can add to it to hopefully try to reach the goals. So non-medical interventions that are important. So these are going to be things that you can do that would not be medication. So patients with an EF of less than 30% should get a defibrillator put in to prevent cardiac death. Patients with less than 35% who have a class 2 or class 3 symptoms, New York, on chronic GDMT, they do recommend that you would get a defibrillator to help reduce mortality. That is a class 1A recommendation. There are 2 companies currently that do wearable defibrillators. That's going to be LifeVest by Zoll and Assure by Kestra. So either one of those 2 options is what they wear typically after they're first diagnosed with heart failure. They get on their goal-directed medical therapy. They would wear this LifeVest so that they can be on chronic medication for at least 3 months. If they don't have any improvement of their EF during that time period, then they would go ahead and transition to an implantable defibrillator. Now, the next thing to talk about is with the defibrillator is cardiac resynchronization therapy, or CRT. Whenever somebody has a dilated out heart, if they have a large enough bundle branch block, they're going to end up with RV dysfunction and LV dysfunction, and they're going to start squeezing at different times. And so having them squeeze at the same time is going to be your cardiac resynchronization. And so by doing that, it does improve cardiac output and kind of improves mortality if you can get that to happen with it. So in these situations, you're putting not just a pacer in the right ventricle, but you're also putting it so you can pace the left ventricle. And this is typically done by putting a lead through the coronary sinus and on the outside of the left ventricle, and it coordinates both a RV and LV contraction at the same time. So you can see here in this picture, as you have the red lead going into the right ventricle, and then you have the blue one going through the coronary sinus and sitting on the outside of the left ventricle, and that will coordinate that biventricular response. So for patients who have an EF of less than 35%, left bundle branch block with a prolonged QRS of greater than 150, they do recommend BiV pacing with their AICD. So, like I said before, patients with an EF of less than 35%, sinus rhythm, QRS greater than 150, New York classification 2 and 3, chronic resynchronization therapy is indicated to reduce mortality and hospitalizations. If they have it in patients less than 35% and they have a non-left bundle, but they have a QRS greater than 150 with the 2-3 class, then they still recommend it to reduce hospitalizations. And then additionally, patients that are not less than 35%, but 36 to 50%, if they have a high degree heart block, if they're going to be getting a pacemaker anyway, and it's somewhere in that 36 to 50%, it is reasonable to consider it because it will kind of help make sure that the RV and LV are going at the same time. And then patients whose QRS is 120 to 149, so a little bit narrower QRS, but still not normal, if they have class 3 or class 4 symptoms, then they would still consider reducing that mortality and hospitalizations. And then last, EF of less than 30% in class 1. So significantly reduced EF, but just only having class 1 recommendations, it would still be considered to reduce hospitalization. Additional non-medical therapies. So in select patients, if they have this reduced EF and they get a left heart cath and they have the coronaries that have issues, then they do recommend surgical revascularization to kind of help out with the EF. And that is a class 1 recommendation. And then if you have severe secondary or functional mitral regurg, so as your LV stretches, your valves kind of spread apart, you end up with mitral regurg. If you have severe mitral regurg secondary to this heart failure, and the anatomy looks okay, they actually do recommend doing what they call an edge-to-edge repair, where you can kind of pull the mitral valve back together to reduce that severe mitral regurg, get it close to like mild if possible. So that is a class 2A recommendation. And then if somebody has frequent hospitalizations, elevated BNP chronically, they do say to consider doing implanted PA pressure monitoring, and that is a class 2B. So this is something called a cardio-MEMS. This is one of those. They actually implant this in one of the one of the branches of the pulmonary artery, and then that will actually tell you what those pressures are, and it will actually transmit that from home to a server, and it'll let them know what their pulmonary pressures are and help identify if someone's kind of like going into an exacerbation. They can call them up and say, hey, your pressures are going up. I would recommend kind of taking extra diuretics, or go ahead and stopping by the clinic to see if we can avoid you getting hospitalized. And that has led to a 28% reduction in heart failure related hospitalizations after 6 months. So the main points to remember from heart failure is just the 4 pillars. So beta blocker, ARNI, MRA, and SGLT2 inhibitors. And then the other ones are going to be just diuretics for symptoms. And then to get a defibrillator if your EF is less than 35%. Those are the main things to take away from it. All the other ones are just kind of adjuncts that should really be done with a heart failure specialist. Now, to briefly talk about heart failure with mildly reduced EF, there's not really a difference. It just drops all the classes down. So they do recommend basically the same drugs. They just drop them down to class 2B recommendations, whereas just PRN diuretics are a class 1. Same thing with heart failure with preserved EF. You're going to have the same pillars, and they're going to have a drop down where they're going to have class 2B for your beta blocker, ARNI, and MRA, class 2A for your SGL2 inhibitor, and then PRN diuretics is still a class 1. So putting these guidelines together, I like to look at it from the physiology of the guidelines. Why do these medications work? So the increased afterload problem that we talked about, that renin-angiotensin aldosterone activation that causes that increased afterload, the ARB or the ACE or the ARNI will help take care of that. Additionally, the MRAs will help reduce the aldosterone. So that will take care of both your angiotensin and aldosterone part and help reduce it. In terms of your increased preload, things that are going to help out are going to be your diuretics by being able to reduce that volume. Also, your neprilysin inhibitors help out with that volume. And then your SGL2 inhibitors also help out with diuresis and decreasing preload. That decreased ejection time from the increased heart rate, that's where you're going to get the benefits from the beta blocker. And then remodeling prevention are going to be your beta blockers. And then your ARBs, ACEs, ARNIs, those types of things are going to be able to prevent your remodeling. Now we're going to talk about heart failure exacerbation. So this is what we talked about before, was kind of like outpatient management. This is how you're going to titrate all these medications. Now we're going to kind of move it into the hospital. Now you're looking at heart failure exacerbations. And I always look at heart failure exacerbations as a continuum. So you're talking about people that are on the bad part of the Starling curve. You're talking about people that have so much volume in their ventricles that it's overstretching and it's decreasing that amount of squeeze, and you're getting your side effects from being overdistended. So I think it's important to know what that continuum of congestive heart failure is. And so when somebody comes in with congestive heart failure, they either just have congestive heart failure, they have decompensated heart failure, or they have cardiogenic shock. And those are all just like on the same spectrum of the same disease. It just kind of depends on where they're at. As you can see by this table, people that have congestive heart failure, they still have an appropriate amount of cardiac output, but they have elevated CVP, they have elevated wedge pressure because they're congested, they have too much volume in there, but they're not getting side effects of having that increase in SVR or that decrease in mixed venous. They're not having any organ dysfunction or lactic acid production. They're just congested. Once you start getting to somebody actually seeing organ dysfunction from their heart failure, you start getting into decompensated heart failure. So now you're seeing that drop in cardiac output. You still have those elevated filling pressures, but now you're getting an increased systemic vasoresistance, a drop in your mixed venous because you're not delivering as much oxygen. You're starting to see organ dysfunction, but you're still not getting a lactic. You're starting to just see some injuries, but not full-on failure. And then the last part of the spectrum would be cardiogenic shock. And that's where you're seeing a huge decrease in cardiac output, but you're also seeing that organ dysfunction going into organ failure, and you're starting to see that lactic acid production. So here's kind of how it looks. You have your perfusion, and then it goes towards organ failure. And so on congestive heart failure, you're perfused, you're not in organ failure, and then it kind of goes along the spectrum where you're not perfusing at all, and you're in organ failure whenever you're in cardiogenic shock. There's a Forrester classification. This is a 2x2 square that kind of looks at all the different options you could have for somebody coming in. So there's volume status, and you can be wet or dry. And then there's perfusion, where you're going to be warm or cold. So the first one we're going to talk about is just going to be warm and dry. And these are people that are compensated, they're at home, they're living their lives, they don't need to be hospitalized. The next one is going to be kind of warm and wet. Those are the people that are come in that are just in congestive heart failure. They got a little bit too much volume on them. They're starting to be symptomatic, but they're not having that drop in cardiac output. They're not having that organ dysfunction. So they still are warm, as in they're still perfusing like they should be. The next thing you get into would be the cold or decreased perfusion. So cold and dry are either the ones that they just took too many diuretics and they're a little bit over diuresed, they're a little bit dry, they have heart failure, but actually may benefit from getting a little bit of volume back, but they're not perfusing because they don't have enough volume. Or there are people that are not perfusing despite having normal filling pressures and everything being optimized, which is a poor sign. It usually means then they need some sort of advanced heart failure treatment. But the last one is going to be that cold and wet. And this is the most common one you'll see. This will be that decompensated heart failure and cardiogenic shock. This is where they have so much volume on them, but they're starting to have signs of organ dysfunction or organ failure. You're starting to see that lactic acid production. So what is the importance of kind of breaking them down into this 2x2 square is it matters significantly from a mortality standpoint. So if you're warm and dry, you have a 5% mortality, and you can see that cold and dry, you still only have a 20%, but once you're in that cold and wet stage, you have a 50% mortality. So significant mortality differences depending on where you fit on that Forrester classification. So whenever I'm trying to identify a patient that's coming into the hospital, I'll kind of see where do they fit on this. Do I think that they're in that cold and wet stage? Because if I do, then they're going to need to go ahead and get their treatment significantly faster and kind of get on that patient much quicker than if I still feel like they're in warm and being perfused. So inpatient heart failure, now we're going to talk about what we need to do in terms of monitoring and treatment. So I like to use oxygen delivery. So oxygen delivery, I think, is one of the most important equations in the ICU. So oxygen delivery equation is cardiac output times oxygen concentration. And oxygen concentration is 1.34 times hemoglobin times saturation plus 0.003 times the partial pressure of oxygen. So if you need to improve somebody's oxygenation or oxygen delivery, you either improve their cardiac output, improve their saturation, or improve their hemoglobin. So in people with heart failure, they typically have problems where you just need to increase their cardiac output. One of the reasons that we target a higher hemoglobin is because in oxygen delivery, it's going to be very difficult to deliver oxygen if you have two things that are bothering you. So if you have low hemoglobin and low cardiac output, that's going to make them a lot sicker because it's going to be difficult to deliver oxygen. So we usually target a higher hemoglobin, and especially in our heart failure patients, because we know that they're not delivering as much oxygen with their low cardiac output. So mixed venous. Mixed venous is directly measured from the pulmonary artery. It is the most precise. A normal mixed venous should be 65, 70%. That means that after we deliver the blood through the body, there should be about 65 or 70% still attached to the hemoglobin. That's your oxygen reserve in case you need to go run off and do something. A central venous can be taken from a central line, and it is not quite as accurate. You're not going to get the IVC. You're not going to get the coronary sinuses. It's a little bit less reliable. That's why we still continue to put pulmonary artery catheters in. You get a little bit more reliable information. And in heart failure, it tends to read higher than a mixed venous. So if you have a 60% central venous percentage, your mixed venous could be anywhere from 55%, 50%, which is significantly lower than what you're talking about from like looking at the central venous. So if you have less than 65% on a mixed venous, then that is a sign that you're having like typically low oxygen delivery whenever it comes to heart failure. And so your cardiac output is not what it needs to be. If it's greater than 80%, a lot of times that has to deal with like sepsis or some sort of shunt or something that's not going the way that you want it to go. I think it's hard to look at MAP, especially in heart failure. So most of the time when we're dealing in septic shock, we target like a MAP of 65. I think that can be really difficult because the problem with cardiogenic is because of that renin-angiotensin-aldosterone system, because of that release of catecholamines, you really squeeze down that vasculature. And so your diastolic gets really, really high. And so you may have a normal MAP, but still be in cardiogenic shock because you're not perfusing because you're having such low amount of cardiac output. Because we like to say that MAP is directly proportional to cardiac output. And for most of the time that's true, but in a really, really low EF person with really clamped down, they can have a normal MAP, but have very low cardiac output, be very clamped down and not be doing what they need to do to kind of go forward. So if you have a narrow systolic to diastolic difference, you need to consider cardiogenic. And if you have a wider systolic to diastolic difference, consider like septic or some sort of distributive process. Preload. What hemodynamics? We talked about using volume or Vexus. We talked about using CVP. We talked about using wedge. If you want to increase venous return or increase preload, we give volume. If you want to decrease venous return, we give diuretics. If you want to increase contractility, then we typically would give some sort of inotrope, so milrinone, dobutamine, and epi. Milrinone and dobutamine also vasodilate, so we typically call them inodilators. Epi also squeezes, so it increases your blood pressure, and we call it an inopressor. So those are kind of the differences between the two. And if you want to increase your afterload, you can increase it with vasopressors like norepinephrine or vasopressin, or if you want to decrease it, you would want to consider things like nitroprusside or hydralazine or an ACE or an ARB. In decompensated heart failure, a lot of times if we're going to do preload reduction, we would do like some sort of diuretic, furosemide plus or minus metolazone. So you got a loop, you got a thiazide, you're going to do dual nephron blockade. Your contractility agents are going to be your inodilators, so milrinone, dobutamine. Afterload reduction is going to be also with the milrinone and dobutamine a little bit, and you can consider ACE or ARBs if their blood pressure can tolerate it. Again, in congestive heart failure, what you're going to have is you're going to have increased preload. In decompensated heart failure, that's when you're going to start having increased preload, decreased contractility, increased afterload. You're starting to see problems with all three areas of stroke volume. And then you're starting to have that organ dysfunction. This is what we call kind of cardiorenal. So the idea is you have your glomerulus and you have your afferent and your efferent, and there's a pressure gradient. And it's that pressure gradient that gives you a glomerular filtration rate. So as you drop that gradient or lose that gradient, you're not going to be able to have as much GFR. You're not going to be able to make as much urine. And the issue with heart failure is you're actually getting low flow to the kidney, but you're also having that venous congestion. So you see the afferent is going to drop, but the efferent pressure is going to go up. and you're going to really, really drop that pressure gradient, and it's going to make it very sensitive to stop making urine and end up with an acute kidney injury. Heart failure exacerbation treatment. Again, you're going to be looking at diuretics to decrease that congestion. You want to look at your contractility agents, and then afterload reduction. Again, if their heart failure, if their blood pressure can tolerate it, ACE, ARB, ARNI, hydralazine. If you need to do IV and you want to do pure afterload reduction, you could consider something like nitroprusside. And then cardiogenic shock. We can kind of go into it a little bit more. I have a whole separate lecture for cardiogenic shock, but this is where you're actually getting organ failure. You're starting to see that lactic acid build up. You have this entire thing going on where you see the decrease in cardiac output leads to pulmonary congestion, pulmonary edema. You have this increased afterload. You have this inflammatory response. You end up with organ injury or failure of your kidneys, your liver, your intestines, all these high pressures, this whole cycle that we talk about, or spiral. And the definition of cardiogenic shock is going to be decreased cardiac output to the point of tissue hypoxia. So this would be in the presence of adequate volume. So the difference is if you have decreased cardiac output in low volume, you'd be in hypovolemic shock, but this is decreased cardiac output with adequate volume and tissue hypoxia. If you had a pulmonary artery catheter or a swan in, then usually that means that you would have a cardiac index less than 2.2. You can be a bit more conservative and say less than 1.8 or less than 2.2 with support, hypotension, and an elevated wedge pressure or elevated pulmonary artery occlusion pressure. Cardiogenic shock is the leading cause of death in MI. Its mortality can be up as high as 70 to 90% if you don't do aggressive intervention. Before the cardiogenic shock initiatives, you still had a mortality of 50% even with intervention. So it's a very, very difficult disease process to treat. There's different etiologies that will get you to cardiogenic shock, but overall, if it's not treated appropriately, very, very high mortality. Cardiogenic shock often needs mechanical circulatory support. It's a little bit outside the realm of this lecture in terms of talking about how we determine if somebody needs a mechanical support device or a mechanical circulatory support. This will be dealt with in a different lecture, primarily targeting cardiogenic shock. So we'll do that at a later date. The next thing we're going to talk about is just some case reviews, so I can kind of give you an idea of like what my thought process is whenever dealing with these patients. So the first one we're going to come on is just a 6-year-old man. Blood pressure is 106/71. Heart rate's 92. Normal lactic, does have an EF of 21%. So if he's coming in with shortness of breath, you have somebody that has a normal lactic, has a normal blood pressure. They're just coming in short of breath. They're coming in found to be congested. They don't have any dysfunction in terms of like their liver or their kidney. This would be just congestive heart failure. So in this situation, they're on that first one. They're in the good part of that spectrum. They're not having any issues going forward. So normal blood pressure, no organ dysfunction, just elevated filling pressures. There's room to start afterload reduction. So I would typically start an ARB. So the reason that I typically in the hospital would start an angiotensin receptor blocker is I want to make sure they tolerate it. And the reason that I used to do more ACE inhibitors, but with now the ARNIs being so good for their mortality and hospitalizations, I didn't want to go through that 36-hour washout period after starting somebody on an ACE inhibitor to then have to switch them over to an ARNI. And so if they can tolerate starting an angiotensin receptor blocker initially, then it's very easy to switch them over to an ARNI once I know they can tolerate it from a blood pressure standpoint. One of the downsides of this is that the ARBs are typically daily. Maybe some of them are every 12 hours. There are some ACE inhibitor options like captopril that are every 8 hours that would make it easier to titrate. So that's why I typically had leaned towards the ACE inhibitors before, but now I typically just do the ARBs. And then I would just do furosemide IV push in this situation, just because they're just in the congestive standpoint. If they were somehow resistant to IV push, I would add dual nephron blockade. And then if that's still not doing it, I would consider doing an infusion at that point. A good tip, or what I always like to say, is if the patient's diastolic blood pressure is higher than your MAP goal, then you can tolerate more afterload reduction. So if we say we're going to tolerate a MAP goal of 65, then I would say your diastolic 71. It's higher than the 65 that we want. You should be able to tolerate more and more afterload reduction until that kind of gets below what your MAP goal is. Here's another patient. Again, they have an even narrower difference between their systolic and diastolic, so 96 over 76. They still don't have a lactic. They still have the low EF, but you're starting to see that jump in creatinine, right? They have a baseline of 1.1. Now their creatinine is 3.4. You're starting to see maybe a slight increase in their liver enzymes. To me, now you're starting to consider them to be in decompensated heart failure, just because you're starting to see some organ injury from them being so congested. And you can see that they would have grade 3 congestion on VEXAS. You're seeing that pulmonary edema on chest x-ray. So they're going to be in that decompensated heart failure part of the continuum. So in this situation with the decompensated heart failure, you have a normal blood pressure. Now you have that organ dysfunction with elevated filling pressures. But if you look, you still have that super high diastolic blood pressure. So you have a diastolic of 76. If you're targeting a MAP goal of 65, you have a diastolic higher than your MAP goal. You have a lot of room to start afterload reduction. So I would still probably do PO afterload reduction in that situation. If I was really worried about it, I can maybe start thinking about doing IV, but they don't have a lactic. I think they would tolerate just go ahead and trying it that way. And then either doing diuretics as an IV push or an infusion. Now, in this next case, now you have somebody with a very, very narrow pulse pressure. So their systolic and their diastolic being 98 over 84. You're starting to see them being really, really clamped down. They're starting to see that compensatory tachycardia. That lactic is now 7. Now you're starting to get into that cardiogenic shock. You're showing that you're not perfusing. So despite having a normal blood pressure, you're not perfusing like you should be perfusing. So in this situation, now you're having elevated liver enzymes. Now you're having that increase in creatinine. You're showing that you're now in cardiogenic shock because you're having tissue hypoxia. So in this situation, you want to be more aggressive. If you would want to potentially put in a SWAN, and then looking, you have a very low cardiac index, you have that low cardiac output, high filling pressures, high SVR, again, just showing signs that you're in cardiogenic shock. In this is that, yes, your MAP is normal, but you're seeing organ dysfunction, you're seeing organ failure, your pulse pressure is considerably more narrowed, you have that very, very high diastolic blood pressure, very, very low stroke volume, very clamped down. In this situation, I would consider doing something like nitroprusside. You get that pure afterload reduction. And so that way you're really able to kind of like open up that arterial system, vasodilate, and that's going to allow that heart to eject. So in this situation, I would probably start a nitroprusside drip, and I would try to, again, target a MAP goal that would be normal, 65 to 70, maybe 65 to 75. And then I would just go ahead and do a diuretic infusion. It gives you a more steady response as opposed to like these episodes where having large urine outputs at one time. Now, this next one is a big change because now you're seeing this low blood pressure, 64 over 49, MAP of 53. Now you're hypotensive. So now you're tachycardic to 120, your lactic's 10, you have this very, very low EF, but now you're not able to sustain a blood pressure. So this is without a doubt cardiogenic shock. This is much easier to identify as cardiogenic shock than the previous one because you're seeing that hypotension. You're seeing, again, that organ failure. You have the high liver enzymes. You have the high creatinine. You're seeing those high filling pressures with grade 3 congestion, pulmonary edema on x-ray. You have that SWAN in. You have a very low cardiac output, a very low cardiac index, high filling pressures. Your SVR is elevated. This person is, without a doubt, in cardiogenic shock. I just want to say that people a lot of times like to go to maybe vasopressors or inotropes, maybe start Levophed, maybe add epi or dobutamine, or consider doing milrinone, although that does create a lot of vasodilatation that they may not be able to tolerate. And yes, you can start those because the patient's hypotensive. You need to start vasopressors to get their MAP up. You need to start inotropes to go ahead and get that squeeze up because you have a cardiac index of 1.1. But the problem is that the more of those you start, the more it's going to put work on the heart. And so just because you reach your goals on 2 or 3 different medications doesn't mean that that's what's best for the patient. So as you can see, the more inotropes you start, or the more medications you start to try to get their blood pressure and cardiac output up, the worse their mortality. So if you can't get them turned around with just like one, maybe two agents tops, then you need to start thinking about mechanical circulatory support. And that's what we're going to talk about as the next lecture, is deciding when to make that move from just doing medical management to start doing mechanical circulatory support. And then this one, with the MAP being less than 65, I would go ahead and put in some sort of LV support device. This is going to be low flow, low MAP. They're just not going to do well unless they get some sort of support device. And then the last one we're going to look at is a 61-year-old, blood pressure 91/32. Hopefully you can appreciate the difference in with the systolic and diastolic. Now you have this wide difference between systolic and diastolic. For me, this would be more suspicious for like a distributive component. So you start thinking about like septic shock because they have such a low diastolic. But again, they're tachycardic, they have an elevated lactic, they're showing signs of being in shock, but they also have an EF of 21%. So just because you have an EF of 21% does not always mean that it's cardiogenic shock. You can sometimes have a mixed picture. So they do show signs of shock. They have elevated liver enzymes. They have elevated creatinine. They're showing signs of congestion, not tremendous signs, grade 1 congestion versus like grade 2 or grade 3. They still show pulmonary edema. Their cardiac index is low, but not incredibly low. They have filling pressures that are high, but not significantly high. You have an SVR that's kind of like normal almost. And so it kind of puts you in this strange mixed state. So most cardiogenic shocks that we talk about are going to be what we call clamped down. They're going to be low output, high diastolic. The vessels are really, really clamped down. That high diastolic will bring them to a more normal blood pressure. In this situation, you have low output, but you also have this kind of loss of vasomotor tone. You have this vasodilatation, this vasoplegia, as we would call it, where your vessels are not able to clamp down. And this often happens whenever you have some sort of distributive component. So if you have heart failure and you get sepsis, you can have a mixed component. If you have a large MI, you can have cardiogenic shock, but all the inflammation from the heart attack will actually lead to some vasoplegia. You can sometimes see this people that have decompensated after cardiac surgery. They'll be vasoplegic, but also have a low cardiac index. So there's a number of different kind of situations that will give you this mixed picture. And so they have a low EF and an elevated lactic, but they also have this low diastolic. They have a mixed picture. In this situation, you can consider doing like vasopressors and an inotrope like norepi and dobutamine, or you can consider just with epinephrine alone, because it does both, increases your afterload as a vasopressor, but it also increases contractility. I would hold on diuresis on this stage because they're still so inflammatory. There's going to be a lot of third spacing, all that vasodilatation, so they probably won't tolerate volume removal. You want to wait until that inflammation kind of dies down and kind of settles down before you would start trying to get any volume off of them. And sometimes they can even be slightly volume responsive in this situation. All right, thank you very much.